put that in practice, what we heard from the previous speakers, with the patient that we did both procedures simultaneously. So a 76-year-old female, obese, very symptomatic. She had a sternotomy and aortic aneurysm graft a few years ago with normal coronaries. And now she's having multiple hospitalizations for congestive heart failure requiring IV diuretics in the past few months. She has significant functional MR and TEER. And the LVEF is 44%. The RV is dilated with impaired systolic function, and she also has pulmonary hypertension. Comorbidities mainly is paroxysmal atrial fibrillation, some chronic renal dysfunction, COPD, and hyperthyroidism. BNP, as you would expect in a patient like this, is elevated, and is a patient, high-risk patient for surgical intervention. She is on full optimal medical therapy, as you can see here. Nothing is missing. Her chest X-ray. She has RBBB, and even to the last day, AF was in and out all the time. And this is the transthoracic echocardiogram showing the FMR, severe FMR. You see the tethering of the leaflets, even in the transthoracic. And you see it's a wide jet of MR from everywhere. And one would expect that this case might require multiple clips to have a good result, because the vena contractor is wide. And here you see a 3D of the valve from above. No obvious indentations or clefts, and the live 3D with color, and the MVQ analysis showing that it's FMR, the retraction below, and simultaneously you see this massive tricuspid agitation, also very wide jet, severe TR from everywhere. And this is the transgastric. You see it's a tri-leaflet valve, some gap in the middle, and the color is mainly anteroseptal, in the anteroseptal commissure and in the center. So this is our patient, and with that, let's move to the recorded case. Let's go to double, so we save some time. Michael is also here. You can see Michael is there with the transthoracic and the protection from the X-ray. Me, Dr. Koutsogiannis, Dr. Nicolaou, anesthesiologist. This is transeptal puncture. We always do that with a safe sept. We're coming with a Pascal device, so this is the guide catheter of the Pascal. You see the Pascal is coming out in the left atrium, which is not very dilated. There's not a lot of space in the front of us, as you can see, but we managed to close the device to the default position, and now we are bending the device down. It captures the Coumadin reeds here. You see the space is very tight, but with some maneuvers like going posterior and more farther flexing, we're below the Coumadin reeds, and now we're towards the mitral valve, laterally in the mitral valve, and then we do all the trajectories, which are essential. We have to check the lateral medial position and trajectory, the septal lateral in the X-plane view. This is the live 3D for clocking of the device. We have to be perpendicular to the area we're going to capture, which is just the middle of the device. That was the strategy. This is a P10 device. It's a wide device, and we thought that we might be able at least try to see what the result we have with one device in the middle. You see how we corrected perpendicularity. This is a simultaneous clasping. So both clasps are falling down. the device closes, a bit rotated clockwise, as you can see. So we open the device, again we release the leaflets, we counterclock rotate, and then we'll try again. We don't want to distort the valve, so we're coming up, as up as we can get, and we go for a separate clasping. I think this is the posterior. Here, you'll see the posterior falling. Yes, the posterior. The anterior is already inside. And look here, we have a very good result with just one device in the middle. But I don't know why we decided this is not good. And now you'll see another 5 or 6 minutes here. We decided we didn't like it, and we go for something better. And now you'll see we are setting that result again multiple times, because in our effort to improve it, actually, we're not getting such great results. And this is the beauty of this device, of the Pascal device. You can open and close it as many times as you want. It's very automatic. It doesn't damage the leaflets. So you have the luxury to try to get the optimal result with one device. So this is also acceptable, as you can see, very mild. But I guess, again, Michael says, oh, I don't like the orientation.
I don't
so
offhand why.
So we open it again, as you can see, although the leaflets are well in, and we have almost nothing. So I don't know why we decided not to leave it here. We do the measurements like we like it, but then for some reason, again, I think now we started wondering if the posterior leaflet is slipped out a little bit. So we open the device and we optimize the posterior, as you can see. Remember, the posterior is the tethered one mainly, so there is a lot of force there. So we close the device, we measure how much we have in and out.
Optimize posterior, thank you.
Optimizing the posterior. Again. So at one stage, actually, we closed the device and the posterior went out. So it's coming. So it's not that it was our, we were weird to try this. We had some indications, and that the posterior was like very tethered there. Here we're also rotated, so we don't like this. So we open again. And here we also see the hemodynamics. This is FMR, so usually the pressures in FMR, the LA are low. It's not like the DMR when you have a V waves that are approaching the systolic pressure of the left ventricle, like 60 or more. But in the FMR, it's very important to get the mean left atrial pressure and to make sure that the mean LA pressure is falling down, is dropping after you position your implant. So here again, you see these multiple attempts, and this is something that you can only do with this device, not worrying about causing an injury on the leaflets, because it's nitinol and it's spring-like, it's closing. So here, I don't know if we decided to accept this, because that is some time ago, this procedure. I guess no, again. So because it was rotated, so we counterclock again, posterior independently, closing the device. And I guess this time we're not very happy with the color, because we had better color at the beginning. So we'll open the device again. So like I said, in FMR, George, we don't expect huge changes in the pressure, at least the V waves. Now we were rotated counterclock, so we go clockwise. So you see we had a very good result in our first clasping, but we decided we can get it better. And you see now that the procedure becomes, but here you can appreciate how much better the posterior leaflet was clasped. And then the posterior leaflet was out. So again, so when you see these cases, that's why you want to be sure that you have leaflet insertion is 100% good, and you're 100% convinced that it's good before you release the device. So I guess this is our final. So we ended up with one P10 in the middle and with almost nothing of residual, but not. So even that, for some reason, we're not happy. So another clasping. So I guess this was because we were not very happy with the anterior leaflet, how much anterior leaflet we had inside. And I think this is the final. So you see the myocardial, the leaflet bridge, it's very symmetric. So the valve is not distorted. There's very little residual color. And now we release the device. So here is the release, which is very simple. The release with this device, it's just 1-2 steps, and it never fails. So this is our final result. And who would expect to have this result with just one device? But I think our persistence and perseverance with this device to get the maximum, it was granted with success. So same guide catheter, we turn our attention towards the tricuspid valve. Here is an ACE. We use the ACE always for the tricuspid valve, or almost always. So this is coming down. We use the LAO view to avoid the septum, to flex it down to the valve. And then you see the biplane here, midesophageal. We also want here to have the trajectories and the positioning of our device in the anterior, posterior, and in the septal lateral. We want to be in the center and the trajectory to be correct. Here you see that our device is very deep. So our device is almost within the valve. So to correct this, we should gain height, and we do that by counterclocking the guide catheter and then clocking the steerable. And you see how we'll do this, and we'll go higher. And we need to be higher to open the device so it doesn't entangle into the leaflets, because we need to open the device and check the clasps to see which is which. So we do this maneuver now, I believe, to gain height. And also, we check the right atrial pressure all the time, continuously. This is the gain height maneuver I was telling you earlier. You see how we move now higher into the right atrium, and now we're going to open the device. So the device is open, we check the clasp. This is the standard procedure. We should know which is which, and this is transgastric. So we go into anteroseptal commissure, and we need to be, the clocking to be like 2 o'clock to 8 o'clock, to be perpendicular to the commissure, to the coaptation line. And once we find this clocking, then we close the device and we cross the valve, splitting the collar, always targeting the area where the collar is coming from. You see now we moved more centrally in the valve, so the lateral paddle is into the commissure, the anteposterior commissure, so it's impossible to capture something there, so we have to rotate counterclockwise, which we did. We're in the center of the collar, and then we do separately, first for the lateral leaflet, for clasping of the lateral leaflet, that you'll see it here. So you see the lateral, the clasp has fallen, and the lateral leaflet is inside. So now we have to clock the device, the guide catheter, to approach the septal leaflet, and we always check that our this movement doesn't rotate the implant clock or counterclockwise. and then we go higher. You see how tethered is the septal leaflet, so you have to scoop it from below and go up to make sure, and you have to time your movement with systole when the leaflet goes away from the septum. And so we did that. I don't know, we missed the final result. So this is again how we scoop the septal leaflet. So you'll see here how we finished with one device in the intended position and with very significant reduction of the color. And this is how the procedure ended. You saw the timing of the movement up to get it. And this is the final result, a very good result with one device in the interseptal position. Thank you very much. Oh.
Well, it was a wonderful presentation, providing us all the necessity to reevaluate properly the positioning of the device, and this is a great advantage of this specific one.
And this is the 1-year follow-up, if we can reconnect, because this is how you see the P transthoracic, the P10 on the mitral side, and the ACE on the tricuspid side. And this is the result in the mitral valve. Almost nothing. And this is the result in the tricuspid valve, very good. And if you notice here, there is also some moderate aortic regurgitation that we may have to take care in the future. Here.
I've counted 10 times, 10 or 11 times you've done it.
True.
10 or 11.
Yes.
Okay. Any comment?
One question. So we often see combined mitral and tricuspid regurgitation. And we know that in about 30 to 35% of the cases, the TR improves after mitral intervention. Question is, when do you choose to perform a combined procedure, and when you treat only the mitral first and then follow up the patient?
That's a very good question. We have this dilemma every day, as you have in your clinical practice. I think as we're getting more experience and as we're having better devices, advanced generations, more user-friendly, we tend to do simultaneous procedures in patients that have significant problems in both valves. But I think the main reason, the main factor that led us to go simultaneous is first the duration of the mitral valve procedure. So if that is straightforward, simple, and successful. And second is the imaging of the tricuspid side. If you have good imaging of the tricuspid side, then this is like inviting you with significant TR to also treat it at the same time. But we know from literature that only approximately 25 to 30% of patients with significant tricuspid regurgitation get some improvement after you only treat the mitral side. So the question is, can you wait for 1 or in 3 or 1 in 4 patients to get this improvement, and the other 3/4 will come back with problem? It's a very difficult question to answer, and I think if you have the patient on the table, and also for logistics reasons, and if you're convinced that tricuspid regurgitation is significant, not just significant, but massive or torrential, and is not going to improve, then we more and more lately tend to do them together. What is your practice, Dr. Shuvy?
Well, I agree. This is the same questions that arise in our cath lab. And I agree. I think that in patients, when you expect a straightforward procedure on the tricuspid, especially when you use a Pascal that allows you with a similar guide to go to the two valves as compared to the mitral clip and the triclip, and especially when I suspect there's also a primary disease of the tricuspid, sometimes you see some prolapse of one of the lifters of the tricuspid, then I expect that the improvement of the tricuspid won't be sufficient after treatment of the mitral. Then I go, as you said, also to do a combined procedure. But as you said, it's always a dilemma when to say, okay, let's wait to see how is the patient afterwards, and when to say, okay, we are here, let's go also for the tricuspid.
I'll say that the dilemma is more intense when you have a moderate to moderate severe MR, and the main problem is the tricuspid. What do you do in those cases? Do you also treat a moderate MR before doing the tricuspid valve, or you go directly to the tricuspid?
That's a big question. That's a big question. I try, when there is at least moderate MR, I try to treat the MR, because I think it is part of the vicious cycle of the tricuspid disease. So I try not to do isolated tricuspid when there is a significant MR, and moderate is, for me, a significant MR, especially when the patient is intubated and there is estimation of the severity of the MR. So moderate MR under anesthesia, I definitely go for a combined procedure and not doing isolated tricuspid.
Very good. One rare indication to do combined mitral and tricuspid is when you do the mitral, and because of elevated right-sided pressures, you get right to left shunt on the interdigital septum. So that really forces you to fix the tricuspid valve rather than just put a plug in the septal. So we've seen that work very well.
I agree, definitely.
Okay, any comment from the panelists? Dr. Koutsogiannis, Dimitriadis, Leontiadis, any comment? No? Okay, so I have to thank you.